Today we speak of embracing a new era of rehabilitation, or what we like to consider the journey toward human rehabilitation. We have a diverse group of clinical professionals that are watching this overview today. We've done our best, obviously, to try and make this relevant to everyone. The reality is this may come off a little bit more clearly to physical therapists and occupational therapists and possibly speech therapists. But this was designed for professionals across all disciplines in the medical, allied health, mental health, behavioral health, fitness and wellness industries in mind. And even if it doesn't seem tailored to you, as you delve into the full courses, you'll discover how to expand and adapt the specific needs of your profession. And of course, the mentorship itself will be customized to your profession. So this is a very, very brief overview for a complex topic. And our course, Functional Understanding of the Human Rehabilitation, allows you to really get a lot more detail than this and allows you to be able to start right away without having to take any other coursework. We certainly add additional detail in the other coursework that we provide, and we'll talk about what we offer in addition to that. But we highly recommend Functional Understanding of Human Rehabilitation to get a good grounding from here. You can learn more about the Human Rehabilitation Framework from hrfhome.com, which has our white paper, a copy of our clinical manual for clients. And this is something that actually can be rebranded to your organization. We branded it to our clinical company, DMR, but it can easily be branded to any other company, and again, provides client-oriented content that is based in the Human Rehabilitation Framework. And again, right now, since we are the principal developers of the Human Rehabilitation Framework, we are the only ones offering courses, but we hope in the future that others will be taking on this coursework as well and offering to teach their own version of it, because the Human Rehabilitation Framework is an open source project. So how did we get here? Well, we inherently know that the things that we're doing right now are not going well. Patients are frustrated by the impersonal care they're receiving, the fragmenting of treatments and the variety of treatments with all sorts of different descriptions of why they work and different mechanisms that they're supposedly targeting. And in that process, our patients are being overwhelmed and frightened by the medical jargon. They feel unheard, invalidated, and are craving human connection. In society, and unfortunately the very science that we use to really kind of advance ourselves and the statistical methods underpinning them really push people into being fit into these specific groups, these categories, or these labels. The reality is no individual fits neatly into any form of box, any sort of label. And so we have to find a way to move beyond this sort of boxy perspective that we tend to fall into. So what we have to embrace, first off, is that, we live in this biomedical model. And this biomedical model has a number of achievements, but it certainly has quite a few shortcomings, especially when it comes to dealing with health. So, where did it start? Well, it was this focus on biology exclusively, and it's become, again, our dominant model for healthcare. It gained its prominence in the 1800s and has saved a lot of lives. I mean, if we think about what it's done for infection and for disease, many more people are living today than in the past because of advancements in the biomedical model. But as we've learned when it comes to health and well-being, it's been falling short quite significantly. So these significant shortfalls and shortcomings include this excessive reliance on interventions that are targeting biology and isolation, the separation of the psychological and social factors from the biological aspects. This idea that somehow they can be separated really is quite illogical and unscientific on so many levels. And the biomedical model struggles to address this sort of interplay between these biological and psychological and social factors. It adopts this reductionistic approach and isolated problem-solving strategies, which again means that we end up getting these individuals that are being told, oh, this person has just this hip problem or this shoulder problem. And the reality is that this isolated view kind of ignores that a person is more than a single body part or a single problem. And it really overlooks the true complexity of human health and well-being. So this brought us to the development of the biopsychosocial model, which was brought to us by Dr. Engel, kind of the late 60s, early 70s. And he proposed this idea that, again, the biology, psychology, and social aspects of an individual's problem is interrelated, and there's no real separation. And probably a better visual representation would be actually one sphere versus these three spheres somehow integrated in some manner. So while the biopsychosocial model was a significant step forward, it's not without criticism. Specifically, the model has been shown to be, or been discussed to be, too general, too vague, and lacking specific content, lacking philosophical coherence. And this makes a lot of sense when we talk later on about mechanism and this mechanistic worldview, because that's where we predominantly come from in society as a whole, and certainly is the backbone of the biomedical model. So it doesn't feel coherent when we're trying to kind of look at things through this biopsychosocial model, to look at them from a mechanistic worldview. And the model has been reported to lack scientific validity, and that again kind of ties back into that absence of a philosophy of science to underpin it. Bottom line is, little progress has been made since this biopsychosocial model was introduced over 40 years ago, and therefore there's little ability for us to make sense or practical use of it in its current form. We hope we can maybe make an advancement on this. I hinted at this already, but the problem starts with this worldview, this perspective that we take when we look at problems. And when we look at the biomedical model and healthcare as a whole, it is rooted in this mechanistic worldview, in which individuals are treated like machines. And there's this focus on these isolated parts and pieces, and things can be broken, or they might need to be maintained, or they need to be fixed in some sort of way as a whole. It becomes a very reductionistic approach to framing human problems. We're always trying to kind of turn people into machines and pieces and parts, which really never made sense for these organic creatures that we call humans. And it has a tendency to label a complex problem as broken, and leaves the people that have these more complex and multiple diagnoses and multiple morbidities as essentially, being on their own until some unknown future mechanistic solution has arrived. We are proposing in our framework, in our model, is that we need to take on a new philosophy of science. And the one that we have selected, which again we talk about more in our full courses, is this functional contextualistic worldview. And this functional contextualistic worldview embraces human complexity. It comprehensively appreciates the history and the context of the person, and it considers each person's uniqueness and ability to change as a part of the bigger picture. What's amazing, or what we really appreciate about this kind of functional contextualistic worldview, is that it sees humans as having infinite potentials to successfully make things work with whatever problem that they face. We believe that's a really helpful lens if we're going to be dealing with complexity and we're going to be dealing with problems that are human in nature. So as a result, what we are proposing is that we need to transition from fixing machines to working with humans, which means we have to develop approaches that highlight human resilience and adaptability, rather than treating them as machines that wear down and break down and have to be repaired, and things can be permanent and unchangeable. In this process, we have to emphasize the dynamic and multi-level and multi-dimensional nature of human challenges, as well as what that means for their potential for growth. We also need to acknowledge that people can learn and adapt even while they're in the middle of a health crisis or health struggle. In doing so, and in concentrating on supporting the individual where they are, and working with their health issues rather than merely trying to attempt them, we truly believe we have the potential to make a much greater impact on human health and wellness as a whole. In doing so, we have to embrace the challenge of change. And embracing change is a complex endeavor. Altering our own beliefs is challenging enough, but influencing others to change their perspective can be even more daunting. We know what we are proposing is disorienting and it's challenging to take on, but we believe that we have developed the coursework and the content that will help you to make this shift. So in embracing complexity, we are working with the complex interconnected mechanisms and systems of human problems. To do so, we have to introduce what we call, or what is called, processes of therapeutic change. Processes of therapeutic change are dynamic, modifiable, underlying processes that drive treatment outcomes. They are the processes of change that contain these dynamic, multi-level, and multidimensional interrelated mechanisms that are the root drivers of biopsychosocial function. They account for the history and the context of an individual. And here's a very, very key thing. If you don't remember anything other than this, we want to really hit this home. That processes of change are independent from the treatment methods themselves. Treatment must be customized in collaboration with the individual to target specific and/or multiple processes of change. Again, let me be clear. We are focusing on processes, not on interventions, and that is a huge shift from where healthcare is oriented. Healthcare is very much about, hey, what am I going to do? How am I going to fix this person? How am I going to intervene? And what we are trying to state here is that we must clarify problems first before we can act on them by exploring what are the processes of change that are, in this moment, seem to contribute to this person's problem and keeping them stuck. So in venturing into the process-based world, we're going to draw from the pioneers, which are the psychological researchers, Dr. Hayes, Dr. Hoffman, and Dr. Siriachi. What they did is they recognized there was a need inside of their profession of psychology to develop a shared language, a shared understanding, rather than continuously developing another intervention. What they found was, again, there are over 600 different forms of evidence-based psychological therapies or interventions. And what they did is they focused instead on developing an overarching framework that is meta, that is sort of the background in which all of these different types of therapies actually operate. This is, again, where the processes of therapeutic change are involved. And what they did is they developed the Extended Evolutionary Metamodel, or EEM. And again, not to get into too much detail about this, but we have modified it from the original 6 that they proposed in their original EEM to what we call the EEM modified, EEM HRF modified, which is now, again, 9 dimensions versus the original 6. What we have found is that by partaking in this journey along with the psychological pioneers, we already are able to speak across the psychological discipline and domain. And our hope is that by adhering early on to a kind of unified language for process-based thinking, that we're going to truly be able to embrace a transdisciplinary approach to care. So how does this process-based approach work? Well, what we do is we start off with what are the processes of change that we're going to target? And this is the person's functional problem, which is organized by specific processes of change relevant to them and separated into workable or unworkable, or should we say technically adaptive or maladaptive. And then these processes are now targeted by customized and individualized interventions. What we now must do, though, is we must have a measure, some form of outcome that reflects whether the processes of change are in fact changing. And to collect this data, we want to make sure that the data is collected in a frequent manner, because a person's problem can change from morning to night, from day to day. And so we do have to make sure that we have these frequent outcome measures of these processes of change that are relevant to the person's problem. And we can use that to make sure we are accountable to our outcomes. We can make sure that we're noticing when things are trending in the wrong direction. We have to pivot, possibly look back. Are we really targeting the right processes? Do we need to alter the intervention that we're using to target the processes? But essentially, again, make sure that we're staying on top of the problem rather than sort of keep going the course or just missing something important entirely. So to better navigate these processes, we're going to also adopt another science, which is network theory, and we're going to apply it to rehabilitation. What network theory does is it provides a tool to manage complexity. And it's a framework for analyzing complex systems and relationships inside of those systems. It's used in various fields like social sciences, biology, and computer sciences to handle complex issues. And certainly, again, in managing the spread of disease and climate change is some big areas where it's most well known for. But it can be applied to human rehabilitation for the understanding and addressing the interconnectedness of factors contributing to a person's well-being. And the easiest way that I can hopefully make this clear and its value in terms of how do we make a case analysis is to just sort of kind of create a very crude demonstration here of a network in a rehabilitation context. So what we're going to try and demonstrate here is how could a thought relate to increased pain? And so if we have this thought, and this thought has a relationship to emotions, and emotions are primarily sort of this endocrine sort of physiology, and particularly stress chemistry, which is going to result in this elevation of adrenaline potentially. Adrenaline has the potential to be able to increase ion channel sensitivity, or the sensors on a nerve can become more sensitive, in addition to actually sort of triggering the nerves to actually activate. Adrenaline can do both, make things more sensitive and also be an irritant in and of itself. As a result, someone can experience increased pain. So this is a very, very simplified network. And the reality is, even something like this is a lot more layered with a lot of interrelated processes and mechanisms that are involved, and certainly the history and the context in which the problem exists. So with this background laid, here is our proposal for a new way forward to help with human rehabilitation. Of course, we call it the Human Rehabilitation Framework, and it is the world's first process-based biopsychosocial approach to rehabilitation. It is a systematic and comprehensive and universally applicable method to precision medicine, catering to the individual needs and specific movement problems that a person may present with. It also yields transdiagnostic effects. Now, we have to be careful with that term because that term kind of has some philosophical has differences in meaning depending on the philosophy you're looking at it. But essentially, this means that by targeting process of change rather than targeting diagnosis, the HRF is able to address multiple interrelated problems. And this can result in improved management of multimorbidity and concurrent complicating biopsychosocial factors, which can be present even in simple cases. This also becomes a new form of evidence-based practice, an evidence-based practice that is broad in scope, personalized in precision, and has great scientific depth. It is built on over 56,000 critically reviewed scientific studies, and it provides a unified language, a shared language across discipline for a unique transdisciplinary approach to care. We are living in this era where we are looking to shift healthcare towards precision medicine and value-based care. And we believe the HRF is ideally fitted for this because it facilitates personalized care by acknowledging the dynamic history and context of an individual. It enables precision medicine by conducting person-centered analysis of the multiple interrelated dimensions and levels of functional problems. It emphasizes positive outcomes and continuous improvements. It aligns with value-based care using continuous multimodal data and outcome measurement. And the shared language promotes multidisciplinary collaboration. We believe this will lead to a more comprehensive and integrated healthcare approach. And in this way, we really feel like it is an ideal model or vessel for precision medicine and value-based care for rehabilitation. So, with that said, can we actually improve outcomes? Now, it's very early. We have not done significant statistical analysis. We are developing some new case models, and there are some new statistical methods that are actually still, as we're speaking, getting finalized and soon to be published. And so there's a limitation to what we're presenting here, but at least these are some mean averages from our sort of clinical pilot that we have at our clinical site that we have been developing this approach. And specifically, we'll start off with client functional improvements. And to kind of give you the context of the data sample that you're going to be looking at, over 84% of our client base are high complexity cases, which means they have at least 3 factors or comorbidities. They have a central sensitization inventory that is at least 30 points. And again, their history and their psychosocial and social determinants of health clearly indicate that they are struggling, and this is a more complex case. Over 25% of our patients utilize Medicaid, and over 40% of our auto and workman's comp cases are in active litigation. So needless to say, if you're looking for a challenging environment in order to test something, we have that. And that being said, we do also have some very simple people who just rolled their ankle and simple post-operative cases as well. So we've been able to really kind of look at the whole spread of possible applications for the HRF. So let's look at, in general, how we've done. So we utilize the patient-specific functional scale. We're still in need of, again, some new measures that really are individual level idiographic analysis. Patient-specific functional scale is not perfect, but it's the best that we've got right now that we can work with. Patient-specific functional scale has an MDC of 20%. And our clients, on average, see a 30% improvement on patient-specific functional scale within the first 4 visits as a whole. And in fact, we use that as sort of one of our sort of prognostic criteria. If people are not shifting between 20 to 30% within the first 4 or 5 visits, there are some steps that we take to really go back and clarify, did we make the right assessment? Because this is a pretty normal change in function that we should be seeing if you are at least in the ballpark of how their case may be presenting. So now, before I introduce the next outcome, I need to introduce a term based on it, which is psychological flexibility. And so psychological flexibility is the ability to adapt to changing situations while staying true to personal values, and it has a significant impact on health and well-being. And this involves reconfiguring mental resources, shifting perspectives, balancing competing demands, and maintaining flexibility during stressful situations. And we selected this because, well, it's very easy to learn. Specifically, one of the models that embraces psychological flexibility is called acceptance commitment therapy. And acceptance commitment therapy was selected by the World Health Organization because it's so easy to deploy. They were able to deploy versions of it to the public in war-torn regions, including recently Ukraine, and also during COVID because of its ease of deployment. And therefore, we believe that it's a lot more valuable for us, for those of us who are not rooted in a psychological background or a behavioral background, to learn this. And we specifically, as a part of our courses, teach psychological flexibility, not only for our clients, but actually for the clinicians themselves. The Human Rehabilitation Framework was designed that you need to apply these skills to yourself as much as you need to apply it to your clients. And we opted for psychological flexibility as being sort of our approach to integrating some psychological and social skills as being our kind of primary way of entering into that. So now the other reason that we chose psychological flexibility is that when looking at mediators of change in psychological therapies, what Hayes, Siriachi, Hoppen, and others were able to do was develop what was considered the Death Star project, and they did a mediational analysis of what processes actually influence clinical outcomes in psychological therapies. And what they found was a number of different processes exist in the literature. Again, over 54,000 studies that they examined to get down to these processes of change. And what they found was psychological flexibility was one of the strongest mediators of change, followed only by mindfulness, and combined the two produce over 44% of all mediational effects in therapies. So just to put that again in context, psychological flexibility has greater impact on the process of therapeutic change than changing beliefs, self-compassion, coping skills, and therapeutic alliance. So yeah, that's why we felt like it was valuable that was sort of the basis in which we looked at the psychological and behavioral health domain inside of the Human Rehabilitation Framework. So that being said, with physical therapists and occupational therapists, are we able to make some of these shifts? And certainly, again, we would say the same about other disciplines, including physicians and nurses and others who might not be purely in psychological and behavioral health care area. Yes, we are able to make a shift. And we have seen, although it's very early, and again, there's a lot of work for us before we can publish on this work, that as the clinicians get better at this, their ability to influence psychological flexibility also improves, which is a rarity in clinical practice, that things actually get better with time. The opposite is typically noted. We have also seen mental health quality of life. And so again, this idea of these transdiagnostic effects and the ability for us to impact other aspects of life while working on a movement or pain problem can also improve via this approach. Clients like it. And again, we have them reporting that they feel validated and heard, hopeful and confident, and their total satisfaction is also really good overall. So regarding, again, if you are in private practice, or really if you're practice management as a whole, clinical sort of financial performance, national average cancellation rate for rehabilitation, particular physical therapy, for low complexities between 12 to 25%, and greater than 30% in pain specialty. National average for no-show rate is around 10%. At our clinical site, using the HRF, 7 to 15% cancellation rate, 1 to 2% no-show rate, and we have currently 7, soon 8 clinicians. So again, it's not just honing in on a single provider having great placebo effect. We're looking at this as our whole trained staff being able to make these kind of impacts. So getting back to this transdiagnostic and social impact, well, clients are coming off of opioids. They're reducing overall medications, reducing imaging, canceling surgeries. Clients are coming off of disability and starting meaningful careers. Parents are teaching their kids these skills. Spouses and caregivers are learning these skills for themselves. Teachers and professors are sprinkling it into their curriculum. Clients are stating that even though they had been actively seeing counseling, they'd been working with their primary care providers, and again, nothing against any discipline or anyone particular in terms of this, but they stated that by learning these skills in the way that they learn these skills, and particularly psychological flexibility skills, help them to actually make the decision to get into treatment, more intensive treatment, such as substance abuse and eating disorders rehabilitation. And so, again, we are seeing these impacts on multiple domains of life, not just with the problem that they came to us with, in addition to their problem, obviously, improving. So we want to just kind of highlight, how did we select processes of change in rehab? There are millions of possible biopsychosocial processes we could have selected, but we chose the ones that had a strong interplay with psychological flexibility and other rehabilitation processes. We wanted to make sure that, again, if you targeted one, that it would impact others, or it could be more focused on that one process you selected. And in that way, we can use the fewest interventions possible as to make sure that the client retains ease and autonomy in their plan of care. And what we really needed to make sure was, again, that this took account for all rehabilitation interventions that have ever been developed and are likely to be developed. And they had to have high precision, scope, and depth in terms of whether we would select them or not and include them. So the proposed rehab processes of change that we have introduced with the Human Rehabilitation Framework is load capacity processes, motor behavior variability processes, and social relational processes or communication processes. Again, we go into much more detail in the functional understanding course and our other courses as a whole. So bringing it all together, we have the psychological flexibility processes from acceptance commitment therapy, the 6 psychological flexibility processes, combined with the 3 rehabilitation processes. And this yields the Human Rehabilitation Framework. Now, again, a lot of this language is kind of foreign. And so what we really needed to do is, even though this is how we train you, and this is how we train our staff, just to kind of get into the nuances of precision care. However, we needed a translator that was easier for us to be able to talk between disciplines and also with our clients. And this is where the EAM came in, or the Extended Evolutionary Meta Model. And in talking about this, we just need to kind of briefly touch on, we're also incorporating applied evolutionary science, which is applying evolutionary theory to solve practical problems in various fields such as medicine, agriculture, conservation, sociology, and psychology. Again, ultimately to just benefit society as a whole. So what is this EAM, and what is the HRF modified version of the EAM? Well, it starts off with a functional problem. Client presents with some sort of movement or pain problem or other problem. And then there is this level that we have to understand that this problem is operating on. And it's always operating on 2 different levels. It's always operating on the biophysiological level and always on the social cultural level. Now, kind of broad when we think about that. And again, while we can be very selective and very precise inside of that, what we are doing is not actually targeting the level directly. Instead, we are extracting dimensions from those levels. And the dimensions, the 9 dimensions that make up the HRF EAM, is movement and positioning, load and capacity, attentional, cognitive, emotional, self, communication, motivational, and general behavioral sort of processes of change, as being sort of, again, these domain kind of grasps, but specifically we're going to call them dimensions. These dimensions, again, are targeting both the biophysiologic and the sociocultural level. And when we're talking about clinical practice, we're really living inside of dimensions more day to day than we are, or I would say more interacting with the dimensions than we are explicitly working on the levels. Now, these processes of change and these dimensions can be defined as workable or unworkable, or adaptive or maladaptive. And then again, we're not going to get into much here, but this is again drawn from applied evolutionary science, where the plan of care is based on variation, selection, retention, and context, which is that person-centered 2-way interaction that occurs for us to be able to help a person and resolve their functional problem as a whole. How do these work together? I'm not getting into too much detail, but essentially they very much transpose over top of each other. And again, we get into that into our full courses. Reminder, you are human as well. So all of these processes of change, all of these sciences, networking, and all these different things apply to you as well, as much as they do to your clients. And the better you can apply it to yourself, the better you can serve your clients. So let's move on to a case demonstration to hopefully make more sense out of everything that we just introduced. So we're going to introduce Jenny. Jenny is a 16-year-old white female, high school student. She's single. She lives with her parents. She's a 3-sport athlete. Those 3 sports are cross country, basketball, and tennis. She has a 3-week history of bilateral knee pain. Started on the right first, then the left. There was no specific mechanism of injury, just kind of insidiously came on. So we're going to start with a network functional analysis of just that information. And so what we can gather from that information is that there's the neurological process of peripheral sensitization that's present. Peripheral sensitization is going to yield some sort of nociceptive processes, and those are likely what are contributing to her pain experience. So on the biophysiological level, we are looking at these specific dimensions, and again, we're seeing that there's a timeline that's involved in this. So now let's bring in the history and the current context for Jenny. So Jenny is transitioning from cross-country season, so again, very linear, straight running, to basketball with this sort of transverse, multi-directional changing of movement for the first time. So in the first time in her sort of athletic career, she's transitioning seasons between 2 sort of significantly different movement patterns. And even prior to that, she'd been limping for several months after a foot injury. So initially, what we observed on evaluation was that she had this increased stance time on the right lower extremity with nodal reduction of degrees of freedom throughout that right side of the trunk. So essentially, she was moving stiffer at the foot, ankle, knee, hip, and really throughout the trunk and even the arms as a whole there. She also seemed to have visible mild right parapatellar swelling. Palpation of the right patellar complex was sensitive. There's hyperalgesia present. And load testing of that patellar tendon through various kind of concentric, eccentric knee extension provoked concordant pain as well. Her patient-specific functional score was she selected running, cutting, and jumping. So running was 5 out of 10, cutting was 2 out of 10, jumping was 4 out of 10. So again, the lower numbers are that they're functioning poor and not satisfied with it. Higher, they're more satisfied and functioning at a higher level, and so she's not doing super well here. So let's bring that information into her analysis here. So we know that she likely exceeded her tissue capacity of her parapatellar and patellar tendon through the transitioning of the seasons and not being conditioned and adapted to that sport change and those movement changes. There was a immunological process of the spicy adaptive soup that was present. And this likely has a 2-way relationship with the peripheral sensitization because the nervous system and the immune system are inseparable from each other, as well as the endocrine system. But anyway, long story short is that likely, again, is adding to the nociceptive processes and adding to the pain experience. In addition, she talked about this kind of limp that she had. In addition to, we could see that she was limping, and these are motor behavioral processes, and there's this decrease in degrees of freedom of that right kind of lower quarter, as well as unnecessary tension throughout her movement. So let's add in some psychosocial history. She has some history with anxiety, some history of catastrophizing in other contexts. And then if we look at the words that she's using, she's worried that she's damaging her knees and wants to avoid wearing them out. The athletic trainer, and not to, again, poke at athletic trainers, I'm an athletic trainer as well, and her classmates make comments to make her worry about the long-term implications of her sport participation. Now, we don't have time in today's kind of overview to discuss this, but we have basically every month we have studies that are coming out that are showing the harm, the iatrogenic and nocibic influence of our language in healthcare that is worsening individual outcomes. And so I just want to kind of highlight for a moment, while we can't get into much detail, that these words are super important, and we oftentimes ignore the words that our patients are using to describe their problems, and they're very relevant to their problem, as we're going to show here. So again, we had this information already. Now we're adding in, hey, we've got the psychological inflexibility measure, which is the PIPS. And this kind of gives us some information about experiential avoidance of pain and cognitive fusion with pain thoughts, which is a fancy way of just saying that she gets stuck in thoughts related to pain. And she's scoring pretty high on these. So she's struggling a bit with avoiding anything that hurts. And she's also thinking a lot about things related to her pain and avoiding pain. And she started to limit her practice and taking a day off between drill practice, which normally wouldn't be an issue, except she's just laying on the couch. She's not moving. So there's this sort of deconditioning, and her tissues are not getting the loads that they need in between to help her recover. So if we put it all together, now we've got her network. And again, it seems kind of complex, but this is actually a pretty simple network. We can see now the sociocultural influence between her athletic trainer and her teammates impacting her thinking, and the thinking regarding long-term injury and damage to her knees over time being kind of a big theme, resulting in fear. This fear having an impact, obviously, or being directly related to the stress endocrine processes, which is going to elevate cortisol and elevate adrenaline concentration, which that's going to increase peripheral sensitization. It's certainly going to impact the other processes. It's also going to impact motor behavioral processes. So we can see how being able to look from a network perspective, the interrelated, multi-dimensional, multi-level interactions. And as far as we can tell, this is probably the easiest way that we're going to really be able to embrace complexity until we come up with some better idea here. And the cool thing is we're going to have technology such as AI assist us with this in the future. But we're going to talk about that in just a moment. So what do we do with these networks? Well, we're going to target the process of change by customizing interventions specific to her. And again, I can't get into too much detail today because it's going to take forever, but we consolidated those 9 dimensions down to 3 sort of central dimensions sustaining our problem, which are operating again on these biophysiologic and sociocultural levels. We bring in the unworkable in this case, although workable is very important for us to note as well, because we do want to take any strengths an individual has and use it to our advantage as a useful variation. But from a movement standpoint, she's got this, again, kind of stiff, rigid sort of movement as a whole on this right side of her body, and unnecessary tension. She's got these thoughts that are at the cognitive level, and she's got these fears that are related to her cognition, her movement, and her pain. And what we're going to do is we're going to introduce variation, which is going to be creating strategies and providing education to help her to be able to move a little bit freer, a little easier. We're going to introduce different skills from psychological flexibility to help her to deal with some of these thoughts and these emotions. And we're not going to get into selection and retention context today, but long story short is you do have to think about these things. The cool thing is it's not going to take as much time as it seems listening to this for the first time today, you being in the audience. So what were the outcomes from us taking this approach? Symmetrical stance time and improved distribution of forces across the kinetic chain. She looks a lot more relaxed, a lot smoother in her gait, and she's not kind of rigidly holding and guarding herself in movement as she was before. No tenderness to palpation present anymore. Load testing was no longer provocative. She scored 100% on all of her functional scores. Psychological flexibility improved, significantly related to pain, and she returned to sport and drill practice fully without any restrictions. Now, how long did this take? And again, take this with a grain of salt, because this doesn't include the follow texts and emails and things, again, because there's this multi-layer aspect of care that we need to think about in modern care. But in her case, this was 3 sessions split over 4 weeks. So if you're talking about value-based care, it's precisely, that is made precisely for this individual and their problem, it's pretty good. Now, again, this is going to vary. Everyone's results are going to vary. But I wanted to give a simple case example first, and then give you a very quick peek of what a chronic case looks like a chronic low back pain, where again, lots of pieces, lots of puzzles kind of here that seem to be present. But the education that we provide and the technology that we're working on will help to simplify this and make this so much easier. So very quick technological kind of preview here. This right here is two sort of processes of change that we monitored over time for an individual. And this person was provided regular questions every day, whether they struggled with movements or positions. Movement options were easy to find. Same thing with whether they could maintain their attention related to certain things. And what we have here are these little breakpoints, which are important with network analysis, that tell us that something shifted. And what's cool about this is going to prompt us, if they're filling these out at home through devices, to either have an automated response with AI, of course, or we are schedule a follow-up appointment saying, hey, like something happened in this dimension of these processes that we've been working on. What was it? Is it the thing that we did? Is it something else in your life? And it helps us to, again, make better decisions as a whole. And by having this frequent data, what we can do is we can actually use, again, machine learning or artificial intelligence to start predicting processes of change. We might actually learn in advance what should we be targeting, what processes of change are most relevant to this person's case. And maybe we need to pivot. Maybe we're going the wrong direction. And again, what a cool thing. It's kind of like if you're familiar with Iron Man, it's like having your little own Jarvis here talking in the background saying like, have you considered this? I don't know if that's a good idea. And so I really think there's some great potential here. And again, a process-based approach, network analysis, and these applied evolutionary sciences makes this possible in a way that we couldn't do with the traditional models. Taking this further towards research and potentially seeing, even though right now we have to be very careful with the idea that grouping people versus trying to look at the individual, there may be a future where we collect large amounts of data and we collect the processes that are targeted in the outcomes, and we have a large database. We find commonalities between individual networks, and these create clusters of processes. Now, these have to be still demonstrated as being meaningful to the individual. But what's cool is that we can gather from larger data pools meaningful evidence-based data that we can apply at an individual level, but only after we analyzed individuals first. So again, we're really kind of hopeful for this being a new kind of research methodology and statistical technology as a whole there, but a lot more of that's coming in the future. So a lot was covered, obviously, in this overview. And the reality is you have to have training. And as I mentioned before, you can get started with the Simple Functional Understanding course, which is a weekend course if you're doing it live, and somewhere between, it'll end up, by the time they're recording this, I'm still finalizing the online version, somewhere between 10 and 15 hours online. And you can start with that right away. Now, we are actually offering over 150 hours worth of coursework, which includes mentorship. You don't need all of that. There is a certification if that's important to you or to your group. Our goal is not to be like this, you have to be certified to do this. Our goal is just that you have a lot of support, a lot of content that you can use to help your clients and to become a better clinician, to work on this, this journey of becoming this master clinician as a whole there. So to learn more about that, again, hrfhome.com, and then certainly the courses through dynamicprinciples.com. Our hope is, in the future that it won't just be us teaching this, but that means that hopefully someone there out in the audience right now is starting their journey and hopefully willing to also spread these ideas in the future. So with that said, thanks for taking the time to listen today, and we hope to hear from you soon.